Good evening, and I really request Dr. Sharad sir to introduce the chairpersons and give the welcome address.
Thank you. Thank you, Dr. Kundali. Good evening, everyone. Welcome you all for today's Journal Club meeting of TAPISAR. And I'm thankful to Dr. Kundavi, Dr. Vasundhara, and Dr. Sindhija for their untiring efforts to keep it floating. I'm also thankful to our esteemed guests, Dr. Durga Rao and Dr. Krishna Mantravadi for their participation. And as you all are aware, controlled ovarian hyperstimulation is a norm in our IVF procedure. And ovarian hyperstimulation syndrome used to be the dreaded complication and nightmare for the IVF specialists. So then the GnRH analog ovulation trigger and cryopreservation, advances in cryopreservation like vitrification has really revolutionized the IVF procedure. And these days, ovarian hyperstimulation syndrome is unheard, and ovarian OHSS clinics have become a norm around the world. Yeah. Then, but 25 years back, after the controlled ovarian hyperstimulation, many a time used to come across ovarian hyperstimulation syndrome, which is going to be a dreaded complication for a nightmare for all of our IVF specialists. No, so then in vitro maturation has come into vogue to avoid ovarian hyperstimulation syndrome. Somehow it didn't catch up with the IVF specialists and confined to the university clinics. No, so now with this brief introduction, I'm really looking forward to listen to Dr. Durga Rao and Dr. Krishna, how the biphasic in vitro maturation will replace the traditional in vitro maturation. Thank you. Thank you so much for this.
Thank you,
Thank
sir.
you, Dr. Sharath. So I would just like to sort of...
Let me just introduce you, ma'am. If you can just give me 1 minute. Yeah. Welcome, everyone. It gives me immense pleasure to welcome you all for this journal club, which is going to focus on a paper that pushes IVM into entirely a new era. And it gives me much more pleasure to welcome Dr. Durga Ji Rao, who is a popular voice in the field of reproductive medicine with over 25 years and above of experience in the field of reproductive medicine, and who has a great interest and has done a lot of research in the field of IVM. It's a passion for her. So we are very much honored and privileged to have the entire team of OSS who has done a lot of research and doing ongoing work and achieved successful live births following this Kappa IVM protocol. And we know that over a few decades, maybe more than 4 decades, there has been static culture systems, and this biphasic IVM, especially Kappa IVM, which is going to offer much more physiological and safer and clinically meaningful outcomes for our patients, especially high responders and PCOS. However, there could be some extended benefits out of this Kappa IVM in future for fertility preservation and patients with severe medical conditions who cannot undergo the COS control ovarian hyperstimulation. So without much ado, I would like Madam to be the expert for this session, and the presentation is going to be done by Dr. Kavya Jalgam Rao, who is the regional head and also the center head at OSS Warangal. She's a very good friend of mine, and she's got a lot of work along with the entire team in IVM. Over to you, Durga ma'am and the entire team. Welcome you again.
Thank you, Vasundhara. It seemed so familiar, so I didn't stop to get introduced because, the association that we have had for so long. But thank you very much for the introduction and the invitation as well. And, Kavya, Dr. Kavya, who's heading our Hanamkonda branch, is the ideal person to actually start this journal club, because she's been the driving force behind IVM. Krishna and me remain in the scenes, and it is his team, Gayatri leading the way with Dr. Kavya in the clinical aspect. And I think most of the cases that we have done and we have presented across, even in Eshe and other places, have been mostly, because of the entire work of Dr. Kavya. So we thought it would be, appropriate that she presents this, the article, and we will what we would like to do is, keep it free and open for everybody to ask us as the topic goes on. So, that would really create more interest and good dialogue. And we have done some cases which, if time permits, we can sort of discuss what our experience has been with Kappa IVM and what our results have been. But over to Dr. Kavya for the actual article presentation, please. Thank you.
Thank you. Thank you, ma'am. A very good evening to everyone. I want to begin my session with extending my thanks towards the TAPISAR team, Dr. Sarath Batina sir and Dr. Radha madam and entire team, Dr. Vasundhara, Dr. Sindhuja. And a huge thanks to Dr. Durgaji Rao madam and Dr. Krishna Chaitanya sir for lending their expertise in guiding this session for today. And I would like to start sharing my screen. I hope my screen is seen.
Yes, doctor.
So today's topic is very close to my heart, which is biphasic Kappa IVM, an advancement over traditional IVM. So this particular review article is actually from the experts from various countries. First author being Mr. Lan, who heads the Department of OBG at the University of Medicine and Pharmacy. His expertise is in the reproductive medicine and ART. His key contribution was primarily the translation application of clinical validation of Kappa IVM protocol, and his team was the first only center successfully implementing the Kappa IVM technique and reporting live birth outcomes all over the world. And along with him is Mr. Robert, Professor Robert, and who heads the department and is the director of research in the School of Women's Children Health at Australia, Brisbane. His expertise is the oocyte and reproductive biology, specifically oocyte somatic cell communication. And his contribution provided the fundamental biological blueprint for the two-step biphasic approach, which is the Kappa IVM. So going into the details of this article, the challenge with the traditional IVM being is the standard IVM culture conditions have remained largely unchanged since Edwards first described them over 50 years ago, limiting success in ART. Human oocytes from follicles larger than 6 mm mature spontaneously when removed from the ovary without appropriate maternal signals that normally induce maturation in vivo. The challenges in IVM being its success rates low when we compare it with the IVF conventional, and the complexity in the procedure involves the clinical expertise both by the clinicians, the lab, and the embryologists. So what is biphasic IVM? Biphasic IVM has two basic principles. The first is the pre-IVM phase, which is the first 24 hours after the egg collection. The immature COCs are collected from the antral follicles and cultured with C-type natriuretic peptide to maintain the meiotic arrest at the GV stage. And the next is the IVM phase, which is the next 30 hours. The oocytes are cultured in conventional IVM media with supplements to complete nuclear maturation to M2 stage. And then it follows the standard IVF process. Once the oocytes are matured, they are injected with the partner's sperm, and the resulting embryos are handled similarly to those produced through the conventional ovarian stimulation. The science behind this Kappa IVM is...
So, Dr. Kavya, just before we get to Kappa IVM, the couple of things that we really need to reiterate here are things. One is, how is Kappa IVM different from traditional IVM versus conventional IVF? So what happens in Kappa IVM, which is different to traditional IVM, is the additional step of the capacitation that happens, that we are trying to initiate in the oocyte. Now, in traditional IVM, there is no extra step of capacitation. It is directly maturing the immature oocytes in the culture conditions, and then after maturation going towards ICSI. But in Kappa IVM, which is different to traditional IVM, is there's an additional step of capacitation that happens. And the basic principle of that is Now, when you are going straight for maturation, there is a kind of a disbalance between the nuclear maturation and the cytoplasmic maturation. So, what we are trying to do with capacitation aspect is allowing the cytoplasm of the oocyte to catch up to the nuclear maturation. So, that is what is the additional step that is different from the traditional IVM. Thanks, Kavya.
Yes, ma'am. So this synchronicity between the nuclear and the cytoplasmic maturation, capacitating the oocyte for the embryonic development, is the main crux of this kappa IVM. The advantages over traditional IVM being it mimics the natural oocyte maturation in vivo by using EGF-like peptides and FSH to induce the meiotic resumption rather than the spontaneous maturation. It preserves and maintains the bidirectional communication between the oocytes and the cumulus cells through the gap junctions during the pre-IVM phase. Extensive data shows improved embryonic development and pregnancy outcomes compared to the standard culture systems in IVM. The primary patient indications the authors mentioned in this article are the first being the PCOD, polycystic ovary syndrome. Most common indications, the patients at risk of ovarian hyperstimulation with conventional IVM are the primary category. And the next being the high antral follicle count, women with elevated AFC who faced increased risk of exaggerated ovarian response in their previous cycles. Next being the normoresponders, patients seeking milder stimulation approach with reduced medication burden. And lastly, fertility preservation, particularly valuable for oncology patients requiring urgent fertility preservation. Coming to the clinical protocol overview, the patients once selected are actually the PCOS, most of them, who don't get their cycles regular. So the patients can be on an OCP pre-treatment or might not be. For the ones who are not on OCP, we usually give the progesterone withdrawal, and the patients receive 2 to 3 days of FSH or HMG priming in the early follicular phase, starting on any day of the cycle the authors mentioned in this article. The biphasic IVM can also be performed without gonadotropin priming, and strictly no HCG or no GnRH agonist trigger is used in this biphasic step. In this IVM, once the timing of the egg collection is very important here. The timing is usually after 42 to 44 hours after the last dose of HMG is when the oocytes are retrieved. And once the oocytes are retrieved, the laboratory part, now I request Gayatri, who is the regional embryologist, who is closely associated with this work in the lab, to continue the session further.
Thank you, ma'am. Good evening, everyone. So now I'll be discussing the lab aspects of the kappa IVM. As we all know, it's a biphasic IVM system which has two steps. One is the pre-IVM, or also known as the kappa phase, which is followed by the IVM maturation phase. So kappa IVM media is basically a step where the oocytes are exposed for about 22 hours in a specialized media containing nutrients like CNP, estradiol, insulin, etc., which helps maintain the meiotic arrest of the COCs while improving the cytoplasmic maturation. So once the oocytes are exposed to kappa media for about 22 hours, the COCs are then transferred to the IVM media for about 30 hours, which is again enriched with supplements like FSH and amphiregulin, which allow the resumption of meiosis to an M2. So the workflow in the lab is as follow. So the patient is now first prepped for the oocyte retrieval. Once the follicular fluid comes to the lab, the follicular fluid is passed through a cell strainer and the COCs are searched under a stereoscope microscope. Over here, first, the main challenge that we face is that in a normal pickup, we can clearly identify the oocytes since they are aspirated from a larger follicle, so they are surrounded by expanded COCs. Whereas in an IVM, the oocytes have very compact cumulus, which makes it very difficult to identify. Hence, all the follicular fluid that we receive is passed through a cell strainer and observed carefully. So when we collect these COCs, we wash them through several drops of pre-equilibrated handling media to remove the blood and debris while maintaining the temperature. Now, post pickup, all the COCs are now transferred into a 4-well Nunk dish, which contains pre-equilibrated kappa media. Approximately 10 COCs are cultured in each well to ensure that there is no depletion of nutrients to the COCs. And this is now cultured in a humidified incubator for about 22 hours, ensuring that there is an oil overlay to maintain stable pH and osmolarity. So this is the step where the CNPs act for the cytoplasmic maturation. Post 22 hours, we gently wash all the COCs thoroughly through several drops of basal media to remove the kappa media and the CNPs and place the COCs into fresh IVM media, which is now supplemented with FSH and amphiregulin, which resumes the cell cycle, and the oocytes are matured in this media. The oocytes are now again cultured for approximately 30 hours. At the end of 30 hours, we mechanically and enzymatically remove the cumulus cells from oocytes under a stereoscope microscope using hyaluronidase and Hippe's buffer media, and then assess the nuclear maturation of each oocyte. So we record the M2s, M1s, GB, atretic oocytes, whatever is there, and we take images of all these oocytes. Once the M2 status is seen, the sample is then prepared and we perform ICSI on these M2 oocytes. Then the oocytes are cultured in a standard embryo culture media till the time of vitrification. So all the critical considerations that we take a look at in the lab is to maintain strict aseptic technique, calibrate the incubators and check the temperature of each stage to maintain the optimal temperature, which is 37. That includes the laminar airflow heated stage and the heated block. Over to you, ma'am.
Yeah, thank you, Gayatri. So from the time of ICSI, the embryos are left undisturbed till day 3 after we check the fertilization. And most of the embryos are in the cleavage stage are frozen on the day 3. The best embryos are frozen and the remaining embryos are cultured to the day 5. So the study results in this review article. The total number of cycles, 483 cycles across 8 clinical trials using biphasic IVM protocols were performed in various centers. 7,520 COCs were collected, and there are 64% maturation rate in this oocytes which underwent the ICSI. And they reported 39% live birth, healthy babies born from biphasic kappa IVM procedures. The safety profile is the remarkable safety record of having a 0% OHSs. No cases of OHSs reported across 483 cycles in 5 recent trials. This represents a significant safety advantage for high-risk patients with PCOS or high AFC. No increased risk of ovarian torsion or complications from high steroid hormone concentrations after ovarian hyperstimulation have been reported. Looking at the pregnancy and birth outcomes, the clinical pregnancy across the studies varied from 35 to 67%, which is comparable to the conventional IVF in matched populations. Live birth being 20 to 47% rate per cycle with no significant differences in complications versus IVF. And there are no differences in preterm delivery, birth weight, or neonatal complications. The RCT comparing the kappa IVM and the conventional IVF, there are no significant differences in pregnancy complications, similar obstetric and perinatal complications, equivalent preterm delivery rates, comparable birth weights, similar neonatal complication rates. The key advantage being the 0 OHSS risk with kappa IVM versus potential complications with conventional ovarian hyperstimulation in high-risk patients. The children were followed up to 2 years, from birth to 12 months, normal physical development, growth milestones achieved on schedule, no developmental delays observed. From 12 to 24 months, ages and stages 3 ASQ scores comparable to naturally conceived children and no developmental red flags. Overall, preliminary data supports normal developmental outcomes up to 24 months for children born after biphasic IVM. And this is the article which they quoted in this review, which is from the same group of authors from 2019. And this has 76 women and 76 women and 104 women respectively in both the groups. And there were no significant differences in the ASQ scores between the children from both the groups. And the development of the children also, they quoted the same article, which is again from the same group. The use of kappa IVM did not have any significant impact on the childhood physical and mental development compared to the children born as a result of natural conception. So what are the current and future clinical applications the authors are looking at? Is PCOS is one of the most common indication, the primary indication, which is requiring the beginner level expertise. And from the oncofertility point of view, from the ovarian tissue or oocyte pickup requires an advanced expertise. Social egg freezing, which requires mild approach, attractive for the elective fertility preservation. Emerging applications, which is tourism fertility treatment, patients can travel soon after the OPU with certainty due to zero OHSS risk. This was a simplified approach valuable during the health crisis like COVID-19 in those countries, and the ability to schedule the OPU date and certainty convenient for patients and clinics. So the overall key advantages of biphasic kappa IVM is its safety, effectiveness, convenience, compliance, and the normal development of the child and its multiple applications in various indications. The promising future, biphasic IVM represents a promising advancement in ART, offering a safe and potentially more effective alternative to conventional IVM. Its applications in PCOS, high AFC, fertility preservation, and emerging indications highlight the versatility of biphasic IVM and its potential to improve the clinical outcomes. Further research will continue to refine protocols and expand indications, making biphasic a valuable novel tool in reproductive medicine. And I would like to continue further our experience with this particular kappa IVM treatment in our own Oasis Fertility being the first one to offer this treatment for our PCO phenotype population. Along with the previous failed IVF cycles, we have a subgroup of patients which we looked in association with the University of Brussels. We are very happy to tell that the India's first kappa IVM baby was born in January 2023 from Oasis Fertility. So in comparison,
Kavya, shall we just wait to see whether, based on the article that was discussed till now and the findings that you have elaborated, whether there would be any questions that or any doubts that we can clear before we go further and deeper into the concept?
sure.
Yeah. And Dr. Kavya and Dr.
Yes, sir.
Sharath here. You're
Sir.
able to hear me? Yeah.
Yes, sir.
So congratulations for the excellent work you have done on this one, IBM. Yeah. So my layman's question is, when so many advancements are happening and the IVF procedure is made so easy, actually, do you select a highway or a tough pathway for to get the success? No? So just I want to know your this one, because whatever indications you have said, and collecting the eggs from a unstimulated ovary will be very difficult, actually, to be honest to you. So with so much of difficulty you'll be achieving the pregnancy, and so many simpler techniques are available to achieve the same success. I wanted to have your comment, Dr. Durga.
Absolutely, Dr. Sharath. You have just nailed the cons of IVM in your statements already. So you're right. It is the con of IVM is the skill that is required for the pickup and the skill and experience that the embryologist needs to be able to identify the COC complex, which is much more difficult. This is definitely the con. The third, disadvantage is the slightly lower pregnancy rate that IVM has compared to conventional IVF. No question. We all know that in this group of women, we just need one good blastocyst in a frozen cycle, and she would at least go away with a 50% live birth rate. Absolutely correct. Whereas currently, IVM is giving us approximately a 35% chance of a live birth. But IVM is not for everybody, sir.
Yes,
IVM is not for everybody. And like you rightly said, and now currently looking at the fact that we have antagonist protocols, we have agonist triggers, and we can do a freeze-all with all the vitrification expertise that we have and transfer a single blastocyst in a frozen, well-prepared endometrium. Why should we even look at IVM was your question.
Yes.
So my answer would be that IVM is not for everybody in that respect. IVM is specifically for people in whom, there is a higher risk of OHSS. Now, sometimes we do tend to see a spectrum in the PCO people who will require a longer duration of stimulation, probably sometimes much higher doses also, because the ovary is a bit resistant due to the insulin resistance, as well as raised AMH and all of the factors that we know that can contribute to a very slow response or a no response PCO ovary. So in those people, when you are going ahead with a prolonged stimulation, you ultimately end up with OHSS, because that continues to develop and then you have too many follicles developing. So in these women, IVM would probably be a better chance. But you will not know till you have attempted IVF in them, seen the problems, and then you convert them to IVF, which is what some of our people that we have done in the last 90 cases, some of them have been actually that. My second point would be IVM is not going to replace IVF just yet. My point would be that IVM will replace probably 3 cycles of IUI. So the success rate that you get with 3 cycles of IUI, with dropout, with unresponsiveness, with the lower pregnancy rates of an IUI, and the amount that you spend for 3 cycles of IUI, if you spend on 1 cycle of IVM, you get the same live birth rate, if not better live birth rate, in a shorter span of time.
Okay, thank you.
Thank you.
Thank
Dr.
you so
Durga,
much.
Yes,
Dr. Durga, I am Dr. Gopinath here.
good evening.
Good evening. Excellent presentation. Your excellent explanation. And there are a couple of points I thought I'll just put it forward.
Please,
So,
yes.
for example, one is truly designated IVM where you have selected and then you have gone for an IVM. In that scenario, Kavya Rao has beautifully put in 3 significant areas where it is going to be working. So one is on the fertility preservation, absolutely.
So your voice is breaking.
So
We lost your
you
voice.
broke up.
As you have rightly said, it is not going to be a replacement for IVF. So conventional IVF is fairly okay, but this is for only a selective population. That is number one. Number two is, when you normally do an IVF, we do get a lot of M1 oocytes and GB oocytes. There will be a practical question: can we apply this to that particular stata to see that we get more of M2 oocytes? The technical problem there is only when you have completely dissected the zona, we come to know that that is only an GV or OM. So if it happens to be there, what are the additional benefits of using something like, the other cell lines, to use it with the culture medium to see that you can convert that into an IVM. Durga, you are unmuted.
Yeah, sorry,
Durga,
yes.
yeah.
So
Yeah.
you're absolutely right. Like I said, now that is the reason why for us, the patients that we have chosen to do IVM mostly are the ones who have had a previous risk of OHSS and obviously took a long time to come back towards fertility treatments and wanted to choose an option which was much safer for them, IVM. Second indications that we have done at OSS is the ones that like you rightly said, sometimes by the time we extract the oocytes and you denude them, that's when you realize that they are not mature. And at that stage, which comes to your second question, was can we rescue them? The point is that when you're trying to rescue these oocytes without the cumulus complexes around them, your maturation rates are going to be very poor. Which is what the initial slides that Dr. Kavya was showing is we frankly need the cumulus cells because of the gap junctions which are producing all the nutrients that are required for the balance of the cytoplasmic maturation. So that is the reason to salvage a cycle after you denude and there are no cumulus cells is going to be much harder and much more challenging. In fact, those people will have to come back for an IVM the next time round.
There are two options to it. One is probably there is a cell line which is available in US, which you can just take it and then do it as a co-culture. Alternatively, you can try on human ampullary cells. But I have got absolutely no experience. Probably your embryologist will be able to throw a little more light on it.
Yeah.
So,
Sir,
sir,
I'll
coming
add
to
on
the
there.
point that you said about cell lines, now, first of all, like you rightly said, that is not available in India. And the second thing is co-culture also will not give you the same amount of maturation that you're looking at, which is above 80% that, we are looking at. Now, we are stuck at, Krishna, is it at 65% that we are looking at in terms of maturation? So, if we go ahead to try and salvage, we may be able to, but it won't reach the same status of kappa IVF. But yes, Krishna, please add on to
So,
what we were discussing.
Gopinathan sir, what you've mentioned, the treatment is called Fertilo, and we've had one live birth reported. There are at least 36 ongoing pregnancies, and the recruitment in total has been less than 60. Um, the in fact, the SIJ at ASRM just last month was had called all the stakeholders, and we kind of sat down and we looked at different ways of doing IVM, and Fertilo Group did present their data out there. The biggest challenge with Fertilo is going to be the cost, because the cell lines that they have to generate, that needs an absolutely different environment. And these are all done with recombinant technology and then shipped to our clinics. So right now it's only they've tried it in North America and few clinics of South America, but we'll have to still wait and see. But I think Kappa IVM has been there for at least 6, 7 years now, and in fact the Vietnam group has uh, reached 1700 cycles, which is phenomenal. Number one is,
Phenomenal.
and India is at the second place. I think the bottleneck with IVM, be it Kappa or even Fertilo, because these are the only two methods right now currently people are practicing, is maturity of the eggs. I think at least 40% of the eggs that are retrieved from the ovary have been lost because of no maturity in the in vitro culture conditions. And the utilization is something that is questioned by a lot of groups. So, yes, it has clinical advantages, but I think this segment needs to be uh, addressed. So that's why, as Dr. Durga rightly put it across, I don't think it's ever going to be replacing what we do in IVF. Yes, the traditional IVF remains the first line in a lot of situations. It's, the technology is so advanced, the KPIs are so well tested and consistent in our laboratories. We're not saying that, chuck everything to only Kappa IVM, but that group of patients, apart from PCO, I think we don't have huge data set, but some patients of oncofertility where a random start had to be done, we had to pick up because the oncologist said, I don't have time. In 1 or 2 days, I got to start off with the oncotherapy. I think Kappa IVM is a brilliant alternative out there. And, this was just, again, Dr. Durga thinking, when this whole Indian law thing, ART bill came in, we yet to do this. Honestly, this is a thought where we said, if this could all work well, why don't we extend this to our donor program? When the Indian government says don't hyperstimulate the donor, there's risk. We only want 7 oocytes. And then, with whatever data we have, which Dr. Kavya will share subsequently, I think we at least have 7 to 8 mature oocytes in every patient that we're doing. So you don't stimulate a donor, there's no monitoring, and there's minimal risk out there. This could be an economic solution, because in India, where patient is paying out of the pocket, trying to ensure that we never overlook the economics is an integral part of our clinical decisions. It's just not about not yes, patients' safety can never be compromised. The fetal safety never be compromised, but we're paying out of our pockets. There's no insurance, even as on today, which can take care of the patient treatment. So that's where I think Kappa is emerging, but a long way to go.
Can I
Dr.
ask
Krishna?
a practical
And
question?
Dr. Krishna,
congratulations
one
to
second.
Durga and Krishna.
Yes.
A few practical questions I just wanted to ask
Yeah.
as a
Sundara, can
clinician.
I ask one question
Yes, sir.
before you start? No? Yeah. Dr. Krishna?
Yes, sir.
Yeah, thank you so much for the excellent work you are doing. Yes, no, yeah, I do agree with our patients. They have to spend from their pockets because insurance schemes are not covered for infertility. And do you think this is the alternative for our patients? Because definitely, I think our IVM is definitely expensive compared to the ordinary IVF procedure. No, what is your comment on that one?
Not as expensive as a traditional IVF cycle that we would.
Sir, in a traditional IVF cycle, at least for the PCO women, you will have to look at a segmented transfer. Gonadotropins and vitrification and a transfer in the subsequent cycle
Yeah.
is definitely more expensive than IVM. IVM can get cheaper in the next few years. The reason why we are hoping is because we are hoping more people will start, looking and doing more research into the media. Right now, we only have a couple of players who are looking at Kappa IVM and creating the media.
Yes.
So therefore, the shipping of that media for us, it comes all the way from Brussels. So, we get them in batches and we're tending to do it. So there is an expense which is involved. But in the future, should this get more commercial, and it comes down to the same cost of the normal media, it is going to be way cheaper.
Thank you. Thank you,
That's in the
Dr.
future, not now.
Thank you. Sure. Thank you. Thank you so much.
Thank you.
But we have to
Durga ma'am and-
congratulate you, Dr. Durga, for your excellent work. No? Thank you. Thank you so much.
Sir, this
Yes,
is
Dr.
because of the fact that, when I was going through my first in McGill, that was when we had started IVM. So that stayed on with me. And I was very fortunate to have Krishna also from Australia, where they were exposed to IVM. So that's how it just happened. And we're very glad to have had the kind of experience with the good teachers, great teachers like you and Dr. Sharath, similar people who have trained us. So
Yeah, no, thank you. Thank you so much. Thank you. Grateful. Thank you.
A couple of questions with related to practical points. Suppose we start to do IVM and we've made up our minds it's going to be a purely IVM cycle. And Kavya had mentioned in our slide, it can be done for various population groups. For example, hyperresponders, PCOS, normoresponders, or fertility preservation. So how do you tailor the protocol, whether, the dosage of gonadotropins, whether you need to use gonadotropins at all or not, because we don't want the follicle size to exceed more than 10 millimeters. Correct me if I'm wrong. And how do you monitor, how frequently do you monitor the LH levels? And you said the timing is very important after 40 or 42 hours. So, and some practical points, like when you do the egg retrieval, do you use a different gauge needle? Do you want to use a 18 gauge needle? And the pressures are different so that the COCs don't get ruptured. So those kind of practical insights from your end. And also from the lab point of view, Krishna, I just wanted to understand that is the KPIs anyway different for an IVM protocol compared to your conventional IVF? And when do you really make your lab ready for IVM? Like, okay, my lab is now having a stable culture conditions. My KPIs are okay. I want to start my IVM. So after how many cycles of IVM and what kind of, readiness the lab and the team has to have? So I would like to hear from you on all these points.
So, what, if you allow us, is, ma'am, we'll quickly show, because the videos are 3 to 5 minutes, if I'm not wrong.
Yeah.
We recorded it in our theater so that everybody gets to actually see live as to how an IVM in the theater, the needle, and how we aspirate. Dr. Durga has a video, and in the lab we created one video. We'll look at that, and then I think you had very nice pertinent questions. We could take them, ma'am. So Dr. Kavya, if you could just play those two videos for us. So the first one is going to be, what we do in the theater, the clinical side, and then we'll show what happens in the laboratory when we're doing the IVF. I think Dr. Kavi, you've got to double click on the video, I think, which will take you to the YouTube. Okay, yeah. The content is being sent to YouTube. I think there's a bit of lag there. Yeah, but while Dr. Kavi keep trying that to ensure we play it.
Do you want me to sort of
Yeah, ma'am.
orally tell? So
Clinically,
basically, Dr. Vasundhara, coming to the questions that you had. Now, you're absolutely right that we don't want the follicles to cross 9 to 10 mm. Now, the reason why we
that
give
to
at
ensure
least,
we play.
sorry,
Sir, is it not audible, the video?
Actually, we are not. We are on the screen. We're only seeing those two still images, ma'am.
Oh,
yeah,
Synchronous to you.
sorry. I'll just, is
Yeah.
it seen now?
Yes.
yes.
So, ma'am, you can keep speaking because I don't think it'll take the audio.
Okay.
You can keep playing the video. Dr. Durga will talk. Ma'am, you're muted. Dr. Durga, you're muted.
Yeah, sorry. So your question about the gonadotropins, Dr. Vasundhara, is absolutely right. So we tend sometimes to give only 1 or sometimes 2 to 3. It depends on the size of the smaller follicles, keeping in mind that we don't want the largest follicle to cross 9 to 10 mm. Now, in this video, as you can see, the pressure, we are maintaining it around between 90 to 100 only, as opposed to what you would do for IVF, which is upwards of 120 to 140. Now, all the tubes that you can see now will be filled in with the media that will take us through to the for the aspiration. Now, what you were just seeing was the IVF, needle and the IVF follicle aspiration. Now, you should notice the difference between the IVF and the IVM needle. As you can see, the shaft of the needle is at 17 gauge. And you have the tip, the last 4 to 5 centimeters of the tip. If you can see, there is a kind of a gradation which brings it down to 20. So what tends to happen is if the whole needle gauge was at 20, it becomes very flimsy. Now this needle, because it is 17 for most part of it, it is firmer. So when you're trying to pierce the ovary, it goes in very easily. And it also makes sure that the ovary does not move too much. And you'll also have to take care that the pressure comes down to around 90. So this is a very small follicle. I think it's enlarged, which is why you're able to see the follicle on the right as being big. But if you notice, both the follicles have been aspirated with this needle. So the end is what is very important for us. So this is a specialized IVM needle. Now, the other thing is sometimes we tend to also decide on giving just one injection of the, gonadotropin and going straight in. We have done pickups even on day 5 or day 6 because we don't want the follicles to, grow larger than a certain size. Dr. Vasundhara, any other, have I missed any questions on that before we go to the...
Yeah, that's fine, ma'am. Just that, the FSH or HMG dose, we have to strictly follow that 40 to 42 hours.
Correct.
That's very important.
So the last dose is given 42 hours prior to the pickup.
And we always monitor the LH levels before?
No, LH levels have got no implications at all because we already know that there is LH, hypersensitivity in the PCO. So that is not relevant to us.
Okay.
But what I tend to do, which, is something that we have looked at, is that when there is hyperandrogenism and that has not been corrected, it does cause poor quality oocytes and more apoptotic oocytes. So we tend to, if there is any hyperandrogenism, which we check based on their clinical and the biochemical parameters, if there is, we first correct that before we take them for, any kind of ART procedures, including IVF.
Thanks, ma'am.
So the main thing lies in selecting the client and also observing her during the 3 days. The last dose of the FSH or HMG is a deciding factor. That last dose can make the follicles to grow bigger also. This is what I have learned in my initial days. So we decide the dose based upon the patient's BMI also, be it 150 or 225, or we can only just give 75 also. Like the author said in this article, it can be done without the gonadotropins also for a baseline PCO whose antral follicle count is actually more. So would you like to talk about the lab aspects? I'm playing the video. Is it seen on the screen?
Yes, yes, ma'am. So, in the lab, ma'am, I think what's important to get started is basically the skill of the embryologist. I think there is a learning curve because you need to identify those tiny cumulus complexes. They do not have cumulus, that sunburst appearance cumulus, which is nicely expanded. That makes it very difficult. Uh, you tend to miss them so many times. So that's the cell strainer what we use. It's 0.22 micrometer cell strainer from BD Falcon company. So we kind of take that strainer, and then whatever follicular fluid we get, we kind of first put it into that because the egg is 120 micrometer and above. So that will get trapped in the cell strainer there. And then you're going to like take it into your 3 ml transfer pipette, and then you'll have to spread it. So I always keep telling my embryologist, our jobs are like our mothers in the kitchen. You want to practice quality, think of your mother, your grandmother, you'll always get it right. So, and this is what mothers do. At least I've seen my mom and grandmother do, how they pick the small little pebbles in your rice or cleaning up things. And that's what we do, and see how tiny the thing is. And you can only see little cumulus around about 9 to 12 o'clock position. Otherwise, so, and this is, I've gone 5.6 times magnification my stereo zoom microscope, and that is when I'm able to show you. Otherwise, if I'm at the regular 0.25 magnification or zero point 0.5, and it's a little difficult. So training your eye is is so important in IVM. I think this is what takes a little time for the embryologist. But after this, it's basic pipetting, controlling your temperature, pH, osmolarity. I don't really think there's much skill needed. And I think, off late, I see India has got fantastic team of embryologists. Gone are those days where we are questioning the clinical skill and acumen of our embryologists in India. We are way better than any other country. We are on par with them. So IVM, what's the embryology side is identifying them, being a little faster. We don't want them to be exposed too much in the in vitro culture conditions. I think these are the two things that are important in carp IVM from an embryologist perspective. And the last thing to add, what's make the Vietnam people, this is again in the last 6 months they've tried, is there's something called a Saigon protocol. So what they're doing is they do the IVM pickup, and in the same cycle they, post egg collection, they start estradiol, they build up the endometrial thickness, and they've tried a fresh embryo transfer as well. So everything is done in one cycle, so the time is cut short, and everything seems to be working well. But I think they yet to publish their experience. But in the ASRM SIG, they've shown us the Saigon protocol. So if that really works well, another advantage, because in PCO, I think 99% of the times we're doing a freeze-all cycle and the patient has to come back the next month or later. But I think Kappa with Saigon would work brilliant if it really comes well. So that's from our side. Any
Before
other
this Kappa IVM, though it's not available now for us to use in India, ma'am, you really had lot of experiences. I was very privileged to be part of Oasis team and was given free hand to do a lot of academic work. And in that interest, I remember we used to do regular IVMs before Kappa IVMs were not there. For example, even to rescue or a pure IVM cycle itself. So any suggestions there, because you had some amount of good quality day 3 embryos. That time we didn't probably risk it to day 5 because it was not Kappa IVM. So until the availability of this, could you suggest some measures where we can do IVM in certain
So I think, if we are looking at that, the traditional IVM media that is available should also be able to help us in terms of getting there. Now, for us, Kappa has helped us in probably improving the maturity of the oocytes. I am not sure we have the data currently to tell you as to what the difference was in terms of maturation of traditional IVM versus the Kappa IVM that we are doing now, because it has been almost 2 years now that we have completely moved towards Kappa IVM. So we don't have the recent data for comparison, but if done right and we follow the protocol that comes with the IVM media and this thing, I still think in select people that probably would do give you at least a 30% live birth rate, which in some group of people that is better than going for other kind of options if IVF is not suitable for them.
Krishna,
Krishna,
Origin
anything
still
that
has
you...
the IVM media?
Yes, ma'am. I know
Yes.
recently at the ESHRE conference, which happened at Paris, Michael DeVos, again, who has done a lot of IVM work at the Brussels University, he presented this comparative work at their center, uh, single step IVM, which is just putting it into the maturation media directly when they are GVs, versus doing a two-step Kappa IVM. He showed the data. So the maturity on an average was 23 to 30%. It was very low. But once you manage to have a mature oocyte, I think the utilization was decent enough and they were hitting a 30% live birth rate. So the point is your GV becoming a M2 oocyte. And Rob Gilchrist, who's the professor at University of New South Wales, he's done a lot of work on this. He says the reason why a rescue IVM is not working for most of us is because we've given a HCG trigger. The moment you've given a HCG trigger, the gap junctions of all your cumulus cells are lost. So he says now whatever I add to the media, you even put it in a kappa IVM media, the cumulus cells cannot transduce the signal to your cytoplasm. Hence, your maturity rates are going to be pretty low. And then he says, you're doing IVM, make sure there's no HCG trigger. I know the pickups are going to be extremely difficult, but a no HCG trigger is the norm for kappa IVM. So one last, again, seeing a lot of immatures is something that we all have in our practice. And when as an embryologist, I have to go and tell my clinician, look, you gave me 20 eggs, but I have only 2 M2s, 18 are immature. It's so scary sometimes to go on a busy OPD and say that. So what we have tried in most situations in the recent times, if there is no severe male factor, you manage to get 1 million TMSE cells, we don't denude them. At pickup, if the embryologist is suspecting that they're getting dense and compacted dark cumulus, and then the GVs, we keep them separate and we just do a traditional IVF insemination. We all embryologists in India, at least, are so carried away with ICSI. We have forgotten IVF. And I probably have data of only some 15, 16 patients where we've done this. At least 50% of the eggs, I have seen them fertilizing the next day. So if there are 18 of them which are immature, and I've done a traditional IVF, and even if I get 6 fertilized oocytes, I think I've done a great rescue to that woman, avoiding another cycle at least, where there's some utilization that's happening. So all embryologists out there, I know we're talking
But
about
the problem is if it depends on the male factor,
male factor.
That's the only downside to that, is not
If you
possible for
can
everybody.
get 1 million total motile sperm concentration, try it, rather than stripping it and saying it's a GV and discarding it, because a GV, just leaving it in your regular incubator, there's highly unlikely chance that it will become an M2. And M1 can become an M2, but GV to M2 without any support is again physiologically not making sense to us. So probably you should have your protocol of IVF ready, ensure your team is uh, having that SOP, and we all should be looking at IVF. It's a request from my end. As a country, when I go to these international forums, the world is going back to considering doing IVF. Everybody got carried away to ICSI, and we're kind of coming back, totally out of today's discussion, but a small request on this platform. IVF needs to come back, guys.
Thanks for those encouraging words. It actually means a lot to give us confidence to, do such things. And definitely, I think many of us are started doing IVF now. If IVM is the next step, but definitely yes.
Lovely.
I think Ms. Gayatri has been waiting for a long time to present.
I think she finished.
It did in between, actually, yeah.
She did present, yeah.
Okay.
All
So
right.
can I just quickly go through the
Yeah.
population
The
set
slide
what
was
we
there. Yeah.
We have done 90 OPUs for 80 patients, and total number of 1,300 oocytes were collected, out of which 625 are matured, which is 48%, and 88% were fertilized, and the embryo utilization is 43%. When we look at the clinical pregnancy rate, it is 41%, and the live birth being 34%. When we compare this data with the Vietnam data, the M2 rate being 48% versus 50%, which is comparable, and the embryo utilization is also comparable. Clinical pregnancy rate being 41% versus 35 to 45% for the Vietnam group. Live birth rate 34% versus 30 to 36%, which is also comparable. India shows comparable clinical pregnancy rates and live birth rates. India cohort includes higher proportion of difficult cases like metabolic PCOS and IVF failures in our study population. And Vietnam trials mostly in RCTs with optimized inclusion criteria. The clinical pregnancy rates are comparable, suggesting transfer stage embryos still competent because we have done most of cleavage stage transfers and they have done blastocyst. And Kappa IVM performance remains within the expected global range. India results align broadly with international Kappa IVM performance. Comparable CPR despite lower blastocyst for few of our clients. The future goal is to improve maturation and blastulation using the protocol refinements. Our data adds valuable evidence from the South Asian PCOS phenotype, and Kappa IVM is a validated treatment option to be considered in PCOS women. The future, as we have discussed, we need better culture conditions and maybe oocyte donations. For oocyte donations, we can consider IVM. And majority of the IVF ICSI cycles, when we do minimal stimulation, most of the times we collect the follicles which are bigger than 14 mm, and the smaller ones can be considered for IVM. Social freezing, maybe. And our thoughts, like Dr. Durga ma'am have told, currently Kappa IVM in Oasis is being offered to the PCOS clients who are looking for a quicker, better, safeable option with lesser gonadotropins. When we look 3 to 4 cycles of IUI versus Kappa IVM, definitely it's a safer probable alternative to that, and also IVF in this good responders and high responders. So thank you, everyone.
Thank you, Dr. Kavya.
Hello, Vasundhara.
Yes, ma'am.
I just have a doubt. I can ask Krishna.
Please, ma'am, please.
Because he said when you aspirate, when you get immature oocytes, you leave it for IVF. I mean, for insemination. Can you hear me?
Yes, ma'am.
You said when you there is a pickup, lot of immature oocytes are there. You leave it for normal IVF, conventional IVF. You said, and it's getting fertilized. So I just wanted to know if this is you identify the immature oocytes with the cumulus complex, or after denuding the thing you found out this is immature oocyte and you inseminated the oocyte with sperms.
Ma'am, this is a tech pickup, ma'am.
Mm.
If you denude them, then
It will not fertilize. It will not attach. The sperms
Yeah.
will not get attached. So
You-
it was not clear for me. How did you? When in the normal IVF pickup, OM pickup, when there are immature oocytes, we can inseminate. But how did you identify the So when did you inseminate, with the cumulus complex or after denuding it?
So no denudation was done, ma'am. At egg collection, sometimes, if you're not having a typical sunburst appearance,
Yes.
properly expanded cumulus, you tend to see them dark and immature.
Yes.
And an experienced embryologist actually can pick up those immature this. So we
Okay.
keep them separate. We don't do any denudation provided there's no male factor. We do it. So
Okay.
this is just a thought. I don't think this is backed up with any publications or evidence to say it will work.
Okay.
But, rather than not doing anything, this is something that we all could consider. It's mostly the M1s which probably get converted to M2 and can fertilize. So, if you have no other alternative and you're getting a lot of such dark, non-compacted ones, try an IVF. If you do, because IVM, ma'am, the maturation media right now in India, the only company which gives you is Medicult, which gives the IVM maturation media.
Yes.
And that whole kit is 1 lakh rupees. The shelf life is only 4 weeks. So I don't think even a big chain of fertility center can buy and keep it in stock and not use it in 4 weeks and discard it. A lot of money. And even for one patient, putting it just in a maturation media where the outcomes are a little not the best, again, is not a good solution. So I don't think keeping IVM media, because you don't know which case it will be needed.
Yes, yes, yes.
So this has been the practical challenge with using IVM media in a traditional, normal triggered cycle.
Okay. Yes. Okay. Thank you. Thank you, Krishna. It was very, very, very good. Very excellent work. Excellent presentation. Thank you for your team, Dr. Kavya, everyone. Thank you so much.
Thank you, Dr. Vijay.
Krishna, how do you actually prepare the lab one day prior? How long the media is equilibrated, and how do you actually?
It's the
is it
same, ma'am. It's all the same. Right now, the Brussels University sends us, color coded. It's all sent by those people, so we don't exactly know what is there in those chemicals in terms of concentration. But there's a couple of steps of preparation, but nothing laborious, ma'am. It is quite simple to prepare your media and culture plates. So, what Brussels team has done is they've now commercialized this whole kit, ma'am. In Europe and Vietnam, they've distributed it. In India, I think we're just waiting for the final stages of some licensing and all for it to be imported into the Indian continent. So,
and we need to look at long-term epigenetic changes or something like this with this kappa IVM.
yes, ma'am. There's one paper published again by Brussels University with the Vietnam tissues, ma'am. And they've looked at all the different epigenetic patterns, methylation and acetylation. And at least that paper published in Human Reproduction said there wasn't anything that was deranged. But
I
maybe
think the longest study they looked at was beyond 2 years, Dr. Vasundhara. So till then, they haven't managed to see that there were any more further abnormalities than the routine IVF. In fact, they did a comparison with natural conception, not even IVF conception.
That's quite encouraging. Yes.
Yes, for now. Yeah.
Sharat sir,
Yeah.
any more
Yeah.
questions from your side?
It's an excellent presentation, and we thoroughly enjoyed the presentations and their experiences. No, credit goes to Dr. Durga Rao and Dr. Krishna. No? Congratulations once
Sir,
again,
both of
the
us are
team.
taking the credit, but there are a lot of people who are actually doing the work, and that's the reason why Dr. Kavya and Dr. Gayatri who are helping us to put this together. But yes, thank you so much.
Thank you so much. No, thank you.
thanks, everyone.
So with your permission, shall we close the session, sir?
Yeah, please, Amma, please go
So
ahead.
before closing, I'd like to thank TAPISAR for giving us the opportunity to organize this journal club every fourth Wednesday of every month. And we are more than grateful to the Oasis team, Dr. Durga ma'am, Dr. Krishna Chaitanya sir, Dr. Kavya, and Dr. Gayatri for being with us this evening and for sharing your extensive knowledge on this, first-hand knowledge on this topic, I'd like to say. And I'd like to thank Shield for the platform for organizing this journal club, and Mr. Mohan for making the invite. And our president, Dr. Sharat sir, and secretary, Dr. Radha ma'am, and all the seniors who have joined us today, Kundavi ma'am, Gopinath sir, Vijaya ma'am, thank you all for joining us today. And thank you all once again. Good night.
Good night. Good night.
Thank you. Thank you, everyone.
Thank you very much. Thank you.
Thank you, everyone.